Good evening, everyone. I welcome you all to the 12th AOI lecture series. And in this series, we have two eminent speakers, none other than beloved Professor Mohan Kameswaran. We'll be talking on granulomatous diseases of the sinonasal tract. You know, this topic, when we discussed amongst our members whom to give, then we could not fit anyone for this topic except Mohan Kameswaran. Sir, we salute your father for his contribution towards this topic. And from Maha's side, with big namaskar to him. And then, this topic actually in ISRP, Sunil gave me some topics of this. He said you are supposed to make a talk on that. I said, no, how? You can ask me to give topic on malignancies or tumors or paranasal sinuses, we are ready. He said that everyone can talk. But this topic is something like, very few people can talk. And then that he made an interest, inculcated interest in this with me in that ISRP which was held in Bangalore. So with this brief introduction of Sir's father, I'll call upon Dr. Rajiv Pachori to moderate this session. And I've been given the, responsibility of introducing the moderators. But Rajiv Pachori is known, I don't think anyone needs his introduction. He's from the Agra, a pioneer surgeon who is a great surgical skills and very well organizers of all the conferences we know and his workshops. And over to you, Rajiv, to maintain this, take this platform on from now onwards.
Thank you, ma'am. Thank you. Thank you, AOI. Thank you, Samir sir. Thank you, Dr. Redis, for this wonderful get-together and webinar. And you can say it's a AOI activity, one of the great going activity. And I think one of the most difficult tasks given to me is to introduce Dr. Professor Kameswaran sir. But I think I have to do it. And he is like a dream person for every ENT surgeon. Everybody wants to become like a Kameswaran sir. And he owns, I think, one of the all the most awards related to ENT at national and international. That is true. And that is started when he was doing his MS. He was awarded as a Dr. P.V. Cherian, outstanding PG student of that time. That is started. He has innumerable publications, presentations, articles, journal. He is fellows at different places, and written books, chapters at different levels. So I think he doesn't need so many things are there. The 3-4 pages were given to me. They are with me. I can go on for 2-3 hours. He started the CG, that is the most prestigious cochlear implant group of India. He is the pioneer in cochlear implant, BAHA, ABI, totally implanted hearing aid, so on many things. He is the master of ENT, I would say. He is the father figure of ENT in our country, and I would say all abroad. So finally, in the simple word, I can say he is the very simple and self-effacing human being with a deep empathy for the socially privileged, low privileged class, and he has very strong social commitment. That is the fact with him. He is he is a conglomeration of a dynamic surgeon, brilliant academician, great leader, good teacher, and again, I would say he's a dream person for every ENT surgeon, like me, because I was having the dream that I would be like a Dr. Kameswaran sir, like in future. That was from my side, and again, I would like to thank all of you, and please over to sir, please enlighten us with your brilliant talk. I would be expecting for. Thank you.
Thank you, Rajiv, for very, very kind words. I'm not even sure I deserve it, but anyway, it's very kind of you. I would first of all like to thank the Honorable President, Samir, who's a very, very long and dear friend of mine. Comes from a very noble lineage, and it's really such a pleasure to see him occupy the President's post, very well deserved. And also the incoming President, Dr. Parthi, who is like a sister to me, and it's been such a long association with these two people. It gives me a very, very happy feeling to see them both here today. It's like seeing your brother and sister with you. It's a real pleasure. And my sincere thanks to Rajiv, and also my wishes to Preetham, who's again a brilliant young man. I listen to so many of his talks every time I listen to him. I feel so happy listening So, and thanks to all of you who are here today to share this evening with us. I mean, this is a remarkable activity. I know that so many people have been following this series of webinars organized by the AOI with the interest taken by the president, the incoming president. And it's benefited a lot of people. My own postgraduates have been attending, and they've all benefited so much. So I think it's a wonderful activity, and people are becoming very knowledgeable. Now, the talk today, which has been given to me by Samir, is a rather unusual talk, because as Bharti said, it's not a very popular topic, but nevertheless, it's something that's very, very important for both for exam purposes, but also more important from day-to-day practice. It's become extremely important, and we need to know these conditions. We need to be aware of these conditions, also able to manage these problems, because they're not at all uncommon. We see them quite often, and today the word shrinking, the word tropical diseases has even now lost its relevance, because it's no longer tropical. It's really quite ridiculous. So let me start off by sharing my screen with you all. So I'm going to be focusing on the granulomatous disease of the nose. It will include also some of the tropical diseases. So we will talk about, but first of all, an acknowledgement to my colleague, Dr. Kiran, who is, without whose help this just would not have been possible. She's been my student and then now my colleague, and I'm really blessed to have her with me. And she is a fund of knowledge and information. This is from the Scott Brown 8th edition. This very busy page literally underlines the complexity of the problem. So, here you have this whole lot of granulomatous conditions, starting from infective, which could be bacterial, fungal, protozoal, or it could be non-infective but inflammatory conditions like sarcoidosis, for example, or the granulomatosis polyangiitis, so-called vaginas, and the neoplastic conditions, which is typically the extranodal NK T-cell lymphoma, which used to be called as the lethal midline granuloma. So these are all some of the examples. Now, we won't talk about the neoplastic condition, but let's talk about the other problems. Now, Sir Patrick Manson Barr, so this is a gentleman who should be always remembered whenever we talk about tropical diseases, and particularly any granulomatous diseases. Now, he is the father of tropical medicine, and he lived last century. He was in the colonial service as a doctor posted in Hong Kong. And in Hong Kong and mainland China, he came across several of these diseases, which were not then understood or illustrated. So he started methodically documenting these cases and writing about them in such a lucid way that when he went back to London, he got it all published in the Royal Society of Medicine. He presented it in the Royal Society of Medicine. And this led to starting the discipline of tropical medicine and starting the School of Tropical Medicine in London, which is till date is considered as the mecca for tropical diseases. So he was the person who founded the School of Tropical Medicine in London, and an amazing person. So he wrote so much about so many conditions, starting from malaria to leishmania and so on, which were then not known at all or not studied. Now, the particular problem in tropical countries now, of course, you have a series of conditions which is present everywhere, but some of them are selective in being more prevalent in tropical areas. That's why we call them tropical diseases. And most of them are granulomatous diseases. So let's look at some of them. It could be fungal, like Rhinosporidium, Aspergillus, we'll talk about it, or bacterial, like Scleroma, Tuberculosis, Leprosy, and so on. And there are also some of them which may be indeterminate. They may be, maybe they are infective, but we don't know for sure, like primary atrophic rhinitis. So let's look at the start off the fungal diseases. So Rhinosporidium. Now, strictly speaking, we typically classify it as a tropical fungal disease caused by Rhinosporidium cereus. But we are not even sure whether it's a fungus. That's the honest truth, because we know that there are many features in the organism which doesn't fit in with the fungus, or in fact with the algae. For example, the the organisms which are more primordial than the fungi are the algae. When the evolution started in the world, the first organisms were the unicellular organisms, and then it gave rise to the algae, and then from the algae came the fungi. The difference is in the wall, the cell wall. In the fungus, you have typically you have a cell wall which is double layered. An algae, which is usually a single layer. Now here in Rhinosporidium, it is a double layered cell, which is why we call it a fungus. But the other difference is the wall also contains is not chitin. It's called the material called chitin, the protein. So it's a chitinous wall, and chitinous wall is normally not seen in fungus. It's only seen in algae. So a lot of people thought this is an intermediate form between an algae and a fungi. So, a lot of confusion there, but now it's being reorganized. The whole thing is being reorganized, and I will come to that in a minute. But it typically occurs in the upper airway, particularly in the nose, oropharynx, and so on. And it was described very early 1900 by Dr. Sieber in Buenos Aires, Argentina. The original article was in Spanish, which is why for many years it was not known, to the English-speaking world. While the Spanish speaker medical world was aware of it, the English-speaking medical world was not aware of it. Only in the late 40s and 50s that it started appearance in the English literature. But in honor of Dr. Sieber, who first described it, it's known as Rhinosporidium sieberi. And the very authoritative monograph of it was written by Dr. Ashworth in the 1970s, actually. So he was the one late 60s and 70s who wrote a very authoritative monograph about the condition. Most of the cases have been reported from the Indian subcontinent and from Sri Lanka. But also we have cases reports from Europe, from North and South America, and also to some extent, a few cases from the Far East. But generally, most of the cases, more than 95% of the cases, are from the Indian subcontinent. As I said previously, it was considered to be a fungus, but now we now call it a protist. Protist is a group of unicellular organisms generally, and these are all primordial, before even the fungus came, and now we put them as Mesomycetozoa. That's a new term, taxonomy for this organism. How does it present? It presents as papular or nodular pink, red, or purple lesions, which are pigmented, and acquire a proliferative appearance, mainly in the nose. Typically, you can see that jutting out of the nose. And the appearance is supposed to be strawberry-like with yellowish spots, which are seen on that. The spots represent the mature sporangia, which has a lot of spherules or these small spores. It's very vascular. So, it's one of the classical presentations is bleeding, and you just have to touch it and it will start bleeding, even in the outpatient. Typically, it has a representation in some states, like the eastern coast, really, Chhattisgarh, Odisha, and Tamil Nadu, parts of Andhra, and also in parts of Kerala. And one of the interesting facts is Rhinosporidium and Rhinospheroma don't seem to coexist, for some various reasons. Now, in areas where scleroma is common, particularly in the middle and in the northern parts of the country, there you don't see Rhinosporidium. But where Rhinosporidium is common, you don't see scleroma, and vice versa. So this is one of the interesting epidemiological facts. So how does it transmit? There's a lot of confusion about transmission pattern, but now it's pretty well established. It is transmitted through water. And how do we know that? This gentleman called Rajmanikam, who did a seminal work, he showed that from the water he found, random analysis of the primer showed DNA, molecular DNA of the organism, which was, which he could match with the organism taken from human specimens. So this put an end to the controversy. So now we know for sure that it is transmitted in stagnant water, where people go and dip and have a bath. So that's how the organism is transmitted. It could also be transmitted by traumatic inoculation, which is important for us as surgeons. So if you're operating on a rhinosporidium, if you go and operate and then in a nearby healthy area, if you traumatize, you will be seeding the spores. And from the nose, it can go into the larynx, usually as a result of endotracheal intubation. So this is one of the facts which has also been shown. And this is more or less iatrogenic. So what are the sites? The usual common site is nose and nasopharynx, to some extent oral cavity and oropharynx. But also you can see it in larynx and the combinations of this. Larynx and you can go down into the trachea and even into the bronchi. Venous, yes, you can see it in venous areas. You can also see it in conjunctiva, nasolacrimal tract, and sometimes in the bone. I'll show you some pictures of this. But majority are in the nose and in the nasal. And mainly, the disease affects mostly males, probably because the habit of having a communal baths is more common in men than in women. And usually it's a disease of Addis. So clinical features, not particularly any typical thing, but generally they have nasal obstruction, rhinorrhea. Epistaxis is an important feature. Sometimes if the nasal acting drug is involved, they can also have epipora and multiple lesions on the skin. So classically, you have this kind of pedunculated lesions. This is the uvula, and you can see behind the uvula also a lot of lesions in the oropharynx. And here is a nasopharyngeal lesion which is hanging behind the palate, and combined where you have nasal and nasopharyngeal. And this is a lacrimal lesion. You can see the fullness of the lacrimal sac, supraglottic lesion filling up the larynx, and here the carina. This is the bronchoscopic view. You can see it saddling the carina. And this is a very advanced nasal lacrimal lesion where it starts hanging around. Interestingly, once you remove it, you can see that it is more or less endoluminal in the nasal lacrimal tract. It very rarely goes outside the tract. It's the lacrimal duct or the sac. But the whole sac can get filled up, and you can see the entire sac is hanging around. And also conjunctival cutaneous. You can have disseminated forms, and here you can see an extensive bone involvement. And we can see this gentleman actually needed an amputation at this level to remove the disease. So disseminated infections can happen. They're quite serious infections, can also be lethal. Involve limbs, the trunks and the viscera. Brain involvement may also be seen, and they lead to fatality, although it's very rare. And underlying bone, when it's involved, undergoes severe destruction. So typically, this is a tracheal rhinosporidium, but you can see how it is coming up and down with each respiration. And the diagnosis is pretty, straightforward. If you've seen one, you've seen it all. So you'll now visit. In just a moment, you see that it's a clinical diagnosis, almost a spot diagnosis. And if you take a biopsy, it's very, very typical. It's something which you cannot miss. You see this very round oval sporangia and spores which are coming out, bursting through the chitinous wall. The sporangia are big sacs filled with a lot of spores. They are quite big. They are up to 50 to 1,000 microns in diameter, and they have these endospores inside them. Usually, the surrounding area shows a lot of inflammation and this hyperplastic epithelium. Here you see the typical sporangium, rupturing, and you can see the spores are coming out. And in a higher magnification, each spore you can see has got a lot of spherules. Each one of them is an infective organism. Microscopic view, and you can see the ruptured spherules coming in and infecting the area. Other stains like GMS, PAS, mucicarmine, and all are all very typically they highlight the organisms, different aspects of organisms, but not needed for diagnosis. If it's just ordinary hemotoxin eosinophil stain, you can pick up the diagnosis very well. As I said, the complications may be life-threatening dissemination, maybe massive hemorrhage, secondary bacterial infection, recurrence. How do we manage them? We don't have any medication for it. That's the simple thing. But there's one stage, people used to be giving them Dapsone and so on, but There's absolutely nothing to say that it works. So today, the main management is by laser. And we did a double-blind study with laser and cautery to show that laser was far better. One, because there was very little blood loss, so these patients didn't need repeated transfusions. The problem so with laser surgery, you can avoid transfusion. And also the recurrence was far, far less. So this is just to show you a video of KTP laser being used. KTP is a particularly good laser in vascular lesions because the absorption spectrum of potassium phosphate (KTP) is the same as oxyhemoglobin. Because of that, the laser tends to get concentrated wherever there is oxyhemoglobin. In other words, wherever there is bleeding. So these vascular lesions will simply undergo fibrosis in no time at all. So in that respect, it's far superior to carbon dioxide laser for vascular lesions. Now you can see a very interesting phenomenon. As you are using the laser, more and more of the tissue will implode. It will fall into the area. It will shrink, involute, and it will get laserized. So it's almost like the suicidal harakiri. It starts falling. The surrounding areas will all start falling. It will shrink to a small extent. And then you can see the attachment very nicely. You can take it out from the turbinate. Here it's attached to the middle turbinate. So you can say take out the whole lesion with almost virtually no bleeding. So there's a huge advantage over the older techniques of diathermy, coagulation, and so on. Now here is a rhinospiridial lesion attached to the epiglottis. And again, you can see with microlens surgery, you can just laserize the whole thing and take it out. This is a particularly sinister lesion. It's coming from the subglottic region, and you can see that it is filling up the whole trachea. So obviously, this gentleman would need a tracheostomy. Generally, we avoid tracheostomy in this patient. Avoid it. In a situation like this, you can't. But you can laserize it and remove it and immediately decannulate it. The idea you don't want to do tracheostomy is because you could be sealing the trachea, which is otherwise uninvolved in a patient. So this is the reason why you want to avoid tracheostomy. Just like in tuberculosis. Next we'll talk about aspergillus, which is another very, very important condition. One of the commonest causes of granulomata in the nose. It's the ubiquitous fungus. Aspergillus is present everywhere. It's been shown right from Arctic, from Alaska to Antarctic. So everywhere it's present. And it has a very complex behavior with respect to the humidity of the host. So how the host reacts will determine the clinical nature of the disease. So at one end of the spectrum, you have a very aggressive disease, which is an invasive, acute invasive form, where it could be lethal, where it is invading into the brain, it is invading into the organs, it is invading everywhere. The other extreme, of course, is the allergic fungal sinusitis, where you have, hardly any reactions. It's mostly a hyperimmune status, where the pathology is caused because of the immunity rather than with the fungus. And in between the two, of course, you have a spectrum of conditions. The aspergillus is a ubiquitous fungus, as I said, and it has a very narrow and septate, very typical septate, and branching at 45 degrees. It's one of the Chinese lantern pattern. It's a classical 45-degree branching septate fungus. You can never miss it under the microscope. And in that respect, it differentiates it from Nucard. It is not very septate, very, very infrequently septate. And also the branching is very irregular. So it's a dichotomously branching septate hyphae, as you can see here. There are two main forms we have to know about. One is the flavors and the fumigators. The fumigators is what is present in most of the Western world. If you get literature from Europe, from North America, they all talk about fumigators. But for us, the more important species is the flavors, the tropics. The flavors and fumigators have very different behavior, and this is very well known to the veterinary surgeons because aspergillus in cattle is a lethal disease. It's a very, very serious disease. And veterinary surgeons are very well aware of it, much more than we are. And they are very aware of the fact that cattle which gets aspergillus fumigators will survive. But if the same cattle is affected by the flavors, it'll die. So the species also is very important. And we have not paid much attention in our literature to the species differences. But you can see the colonies are very different in flavors and fumigators. And this is the flavors which is in, stained in lactophenol cotton blue. In the tropics, we have this so-called rhinocerebral aspergillosis. This is a very typical presentation of, and it is invariably more or less caused by flavors. It's a chronic invasive form of the fungus. So the invasive form, generally acute form, is one seen in immunocompromised patients where it is very, very lethal, rapid, and invariably more or less fatal. But the chronic form is a very slowly, developing invasive form, which goes into the cerebral area, it goes intracranially, goes into the orbit, and so on. And this is seen in the tropics. Now, this gentleman called Mehboob, was a very eminent mycologist. He was the one who first picked this up, and he was from Sudan. Later on, he became even the health minister of Sudan. And he showed that unilateral proptosis in the tropics was most commonly non-malignant unilateral proptosis was mostly because of this particular rhinocerebral aspect. And it is seen in Indian subcontinent, in the Middle East, you see quite a lot of it, Sudan and so on. And as I said, as with these flavors, is the most common organism. As I said, the flavors is inherently a more aggressive organism. Typical unilateral proptosis, is very difficult to listen. And here you see the orbital involvement. And the CT scan will typically show a heterogeneous opacity with areas of increased density because of metal dense spots. And you can see the classical metallic metal densities. You can see how it is invaded into the skull, but invariably it will be extradural. Even though you have an intracranial spread or intraorbital spread, the orbital periosteum will not be invaded, and similarly, the dura will not be invaded. So you know that it is an invasive form, but it is not an acutely invasive form. So here you can see an intracranial spread, but it's extradural. And here you see the lamina papyracea is gone, but still it is not invaded the orbital periosteum. In MRI, it's not very typical. You see a hypointensity in T1 and signal void in T2 MRI. The CT is in fact much more informative. MRI is only helpful to know whether the orbital periosteum is invaded or whether the dura is invaded. Here you can see the invasion into the brain, but still this is extradural. The dura is just thickened and it is being pushed into the brain, but this is still an extradural. The other fungus which is important for us is mucormycosis. And this comes under the group of zygomyces. And there are two orders in this which are important to us. One is the mucorales, which we see the mucormycosis. And the other is entomophthalmycosis, which is known as the entomophthales. So there are two orders, mucorales and entomophthales. The rhinocerebral mucormycosis is a lethal disease of which all of us are terrified. It's caused by the fungus belonging to the mucorales group. It's again worldwide distribution, but more commonly seen in the tropics. It's particularly seen in soil and particularly decomposing organic matter. The spores are in the atmosphere. It's an opportunistic infection, particularly happening in people with immunocompromised state. Diabetics are very, very prone for it. So whenever you see a patient with mucor, the first question you ask is the diabetes, and if the diabetes is under control. And the common species, rhizopus, is a most common cause of the acute invasive form. Angioinvasion is the hallmark. If somebody asks you the pathology of mucormycosis, the one word answer is angioinvasion. It just invades the blood vessels, and because of that, it causes necrosis and even distal necrosis. So it can invade the blood vessel at one point, and the brain may infarct much beyond that. So it doesn't mean that if there's infarction in let's say a part of the frontal lobe, it means that fungus is there. It cannot be. Fungus will be much more proximal than that. Angioinvasion causes coagulation, thrombosis, and then subsequent infarct. The typical mucor and rhizopus, very classical appearance. You cannot miss out. As I said already, it is infrequently septate, which in that respect is different from aspergillus. It's a very thin-walled hyphae, but the branching is irregular, whereas in aspergillus, it's always a 45-degree branching. So called as Chinese Latin pattern. Here you have this irregular branching. The colony also is different. It's whitish or grayish colony or brownish colony. And the clinical features are very typical. You have this very fulminant course. The patient is very toxic, black, necrotic turbinates everywhere, ulceration on the nose, palate. You may have palatal perforation, nasal cartilage will be perforated, orbital cellulitis, cavernous sinus thrombosis, very toxic course, and eventually may lead to brain infarction. Yeah. And in all these years, I have never seen a patient in whom it has crossed the dural barrier, survive and come. In fact, I think there's only one patient I've seen. Invariably, the most critical point to decide whether this patient is going to live or die is whether the dura has been breached. If the dura has been breached and it's gone intracerebrally, very, very slim chance of this patient surviving. Similarly, if the orbit has been breached and if the orbital periosteum has been breached, very slim chance of surviving or salvaging the orbit. So these are the two areas you have to be careful about: the orbital periosteum and MRI will of course help you to know whether this is being. What about its cousin, the Rhinoentomophthalmos microsis? This is also of the same family as before, but it is a less virulent disease. It's a disease which is it also has very similar characteristics to its cousin before, but it's not as fulminant in its course. And the organism responsible is the Conidiobolus coronatus. So entomophthalmos microsis is the name of the fungus, but the organism is Conidiobolus coronatus. And the other organism, Basidiobolus, is also reported in some areas, particularly from Sri Lanka. Presentation, you see nasal discharge, nasal obstruction, multiple polyps, but classically seen in diabetics. And it is thought to be due to minor trauma to the skin or via inhalation. And this is a typical appearance. You have the spreading facial cellulitis, where you have upper lip, face, cheek, and so on. And you have this typical, if you take a biopsy, you see this granulomatous inflammation, multinucleated giant cells with, inside the giant cells, you see intracellular, tubular. And diagnosis is made by microscopy, where you see this again, the same kind of irregular branching, non-septate fungi. It's very similar to mucorinates appearance. The GMS stain and PA stain helps to identify the organism. But the most typical diagnosis is by histopathology, where you see the so-called Splendor-Hopley phenomenon. What is it? You see the fungus, the typical fungus, and around that you see a lot of eosinophilic material, as if there was a star burst. It is going everywhere in all directions. Center you will see the fungus, and surrounded by this eosinophilic material, as if it is thrown away from the center. Known as a star burst appearance, and this is pathognomonic of entomophthalmos microsis. Management is mainly by potassium iodide, usually 40 dose of 40 milligram per kg per day to the lesion. Amphotericin B in a more serious form, and imidazole derivatives like fluconazole, ketoconazole, and triazoles like itraconazole, or a combination of these drugs till the lesions away. But generally, this is not as fulminant, of course, as in. And nowadays, because posaconazole is kept for salvage, because more expensive, mainly for salvage if amphotericin doesn't work. And hyperbaric oxygen Now coming to the next common fungus, which is not very common in our part of the country, but nevertheless, if you take a global scale, this is a very common fungus, histoplasmosis, or caused by Histoplasma capsulatum. It's also known as the cave disease because it is seen in people who are working in caves, particularly in Africa. And Darling's disease because it was first described by Stephen Darling, Dr. Graham Stephen Darling. And Ohio Valley disease because it's very common in the Ohio River Valley in the US. So it is a very common disease in North America and parts of South America. It's dimorphic fungus. It means got two forms. In the soil, it is seen as mycelia, like any other fungus. But when it reaches the body temperature, it becomes a yeast. So it changes its character. It appears as a dimorphic fungus. And it is particularly present in soil with bird droppings and from bat the bat droppings also. That is why it's common in caves. And the spores are, liberated when somebody digs the soil, and the spores are and it's in here. This is a disease which imitates tuberculosis in many ways. So there's the initial infection, just like in primary complex tuberculosis. The initial infection is very silent, and not many people know that they will. But all they may have a mild flu-like symptom. But 3 years later, it may get reactivated. Particularly in HIV patients, it's a very, very high chance of mortality from this fungus in HIV patients. So this is what is very similar in that respect to tuberculosis. The main target organ again is lung. So if you remember tuberculosis, you remember histoplasma. The ENT manifestations, you get solitary ulcers, which imitate in every way as squamous cell carcinoma. It may happen in the tonsil, in the buccal mucosa, in the tongue, lips, pharynx, larynx, and nasal mucosa. Mainly in the upper passage, which we are dealing with. And the treatment, of course, is by itraconazole and IV amphotericin. But majority, is a very mild disease. If a patient is normally immunocompetent, there is no problem. They very rarely it's seen as a C disease. This is a classical histoplasmosis of the tonsil and AIDS area being noted. The other common fungus which is seen internationally is a so-called Paraphoxyloidal Microsis or South American blastomycosis. This, as the name implies, is very common in South America. But today, with the shrinking world, you can all see that I have seen South American blastomycosis or Paraphoxyloidal Microsis. So patients who travel today, they may be exposed and they may come back to you, and then you have to diagnose it. I've seen histoplasmosis, I've seen, Paraphoxyloidal Microsis. It's difficult. You need to, know about it, but we need to know about them. It's an infection caused by Paraphoxyloides brasiliensis, most common, and Lutzi. So as the name implies, it's very common in Brazil, South America. And it is typically, it affects the lymph nodes, skin, and it also causes enlargement of the liver and spleen, and occasionally the upper respiratory tract. This is acute form. The acute form is seen in children. The chronic form is seen in adults. So that's how we must remember. So acute in children and the chronic form many years later may happen mainly in adults. And the chronic form mainly affects the larynx and pharynx. So they have dysphagia, they have hoarseness of voice, and then they may also have hemoptysis and so on. Now, the infection is thought to be from the soil. There's animal carrier, which is the armadillo. And this is a typical reservoir for the infection. Human-to-human transmission is not known. Even in histoplasmosis, for that matter, it's not known. A demonstration of the fungus is how we diagnose it. And there's also antibody tests, and typically the amphotericin and itraconazole are the So this is a typical, acute form in children. You see multiple skin lesions, and then it will go away. But in the adult, it may present as more in the upper respiratory tract, the larynx and pharynx and so on. Now, what about tuberculosis? Tuberculosis again is a ubiquitous disease, but it's a disease which is much more common in our part of the world. And we all know that there's a primary or secondary tuberculosis. And although it's very rare, it's also one of the common differential diagnoses of nasal granuloma. What about the nasal tuberculosis? It's usually due to direct inoculation by nose picking or by fingernail trauma, or from open pulmonary tuberculosis, very rarely by hematogenous spread. And you usually see a soft tissue mass mainly in the inferior turbinate. The way to remember it is tuberculosis affects the cartilage, syphilis affects the bone. So remember that. So tuberculosis always affects the cartilage more than the bone, but syphilis affects the bone more than the cartilage. So here you see the lesion which is attached to the septum or to the inferior turbinate. And diagnosis, of course, we all know by smear, histopathology, culture. Nowadays, PCR is also very helpful. It is an acid and alcohol fast bacilli. In that respect, it is different. The organism is different from leprae. In leprae, it is acid fast, but not alcohol fast. But here, it is tuberculous lesion. You have Mycobacterium tuberculosis is acid and alcohol. And the pathology is you have this typical caseating granular matter with Langhans giant cells. And of course, we know the antituberculous therapy. And in nasal tuberculosis, at least about 6 to 8 months, generally 8 months of therapy is given. The next cousin, of course, is Hansen's disease or leprosy, which is named after Gregor Hansen, who was from Norway. Interestingly, this disease was first demonstrated in Norway, all the places. And Hansen was from Bergen, which is a city which is right in the Arctic Circle. It just shows you how the disease, how widespread it was in the earlier part of the century. Today, of course, most of the cases are reported from Indians. Acid fast bacillus, but not alcohol fast, because it's got a lipid coat, so it's destroyed by alcohol. Mode of entry is by upper respiratory tract and skin occasionally. And it has a predilection for skin, peripheral nerves, and upper aerodigestive tract. Mainly affects the mucous membrane of the nose, nasopharynx, oropharynx, oral cavity. It may also affect the pinna and the facial and cervical skin. Typically, it has features which you can make out. Now, there are about 2.2 million cases worldwide, and 1.6 million of them are in India. And it's also occurred in high incidence in Africa and parts of South Asia. The anteroom of the inferior turbinate is the most likely site where you can pick up the bacillus. The earliest organ involved is the nose in lepromatous, which is the more common type and the more aggressive type. And pinna, palate, and larynx, and also epiglottis may be involved. First, there is a catarrhal stage where it's more like an upper respiratory tract infection, or rhinorrhea, and so on. Then the nodular stage comes with multiple nodules, ulcers, cartilaginous septal destruction, saddling of the nose, alar deformity, and second. And then the skin lesion spreads to skin, pinna, other parts of the body, invading the nerves also, which causes anesthesia, cutaneous anesthesia. Typically, you have this anesthetic spots, hypopigmented anesthetic spots in the skin, which is common. And if you have less than 5, it is known as quasi-bacillary. If it is more than 5, it's called multibacillary. So you see the Mycobacterium leprae in the nasal mucosa. As I said, the typical site for biopsy is that of the inferior turbinate. And you will see in a lepromatous type where there is less immune reaction to the you'll see a lot of crusting, serosanguinous discharge, highly infected, and you'll see nasal obstruction. Earliest features are this nodular thickening of the mucosa, but the collapse of the anterior bridge of the nose. One of the very typical pathognomonic signs is destruction of the anterior nasal spine, which is demonstrated radiographically also. And this is one of the very few infective granular matter in the nose where you have a destruction of the nasal spine. Usually, the anterior nasal spine is very vascular and withstands any amount of damage to it. It is not destroyed normally. Only in trauma it will be destroyed, but in leprosy it is typically destroyed. So it's almost a pathognomonic sign. So destruction of cartilage and bony nasal cells, large areas of perforation and secondary artery. The tuberculoid type is a more, very good response from the very good immune response, much better prognosis. You have the lesion extending up to the vestibule, but will never cross into the mucous membrane. Only involves the skin. But cutaneous anesthesia is a classical feature of this. And there's a borderline where you have a bit of involvement of, but here also the mucosa is on. Typically, you see the great auricular nerve, which is thickened. You see the ala, which is destroyed, saddling of the nose, and involvement of the skin. So it's all very typical. Treatment, as I said, it would be quasi-bacillary with less than 5 hypopigmented skin patch, or multi-bacillary with more than 5 patches. There are 3 drugs which are used now in multi-drug regime. Over that, one is dapsone, which is diamino-diphenyl sulfone, clofazimine, and rifampicin. In quasi-bacillary or in tuberculoid types, usually 6 months treatment. But in lepromatous type or the multibacillary type, usually more than 12 months. Pyroma is again a granulomatous disease caused by the fish bacillus, first described by von Hebra. Primarily affects the nose, but also affects nasopharynx, other upper respiratory tract, including the paranasal sinuses rarely. It's a diagnostic and therapeutic challenge due to its chronic course and need for prolonged treatment relapses. Early detection is very, very important. And usually you have 3 stages. You have a catarrhal stage where it's very just non-specific rhinitis. Then it has a granulomatosis stage where it's much more typical in its histology. And a sclerotic or cicatrical stage where there is multiple deformities due to fibrosis. And histologically, the classical presence of two types of cells, the Mikulic cells, which is a home cell, and Russell bodies, which are nothing but plasma cells, which are distended with the Golgi apparatus. So the Russell bodies are not typical or not pathognomonic of scleroma, but it's present a lot of chronic inflammations. But the combination of Russell bodies with Mikulic cells, home cells, are very, very typical. So diagnosis by biopsy and culture in the blood agar. The rhinoscleroma is a positive organism. Klebsiella rhinoscleromatis is a positive organism. Shown by typical stains like the GM stain or Gram stain. And imaging may show a V-shaped soft color, which is not very typical really. And nowadays we have, of course, immunohistochemistry also, which is diagnosis. Treatment, it responds to a lot of antibiotics. The only thing is you have to treat them for a long time. The drugs of choice today are tetracyclines, particularly doxycycline, and ciprofloxacin, and also to some extent rifampicin. Even give them combination therapy, but we have to give them for at least 6 weeks, sometimes even up to 3 months. So, and the surgery, very limited role, particularly the secondary involvement of structures. Lasers for release of scar tissue in the cicatrical stage. Irradiation, no, not at all. I mentioned in some books, but I just put a question to say not used. Reconstructive surgery after the disease is brought about. Leishmania is again caused by protozoa. The interesting fact is that the first discovered by Leishman and Donovan. Donovan was the Surgeon General of. He was based in Madras those days. He was also the professor of medicine at Madras Medical College. And there's a ward even today in Madras Medical College is named after him, one of the Donovan ward. And they discovered the protozoa, from natives who had Kala-Azar, from Indian natives who had the disease. The three main types, the visceral types, one is the Kala-Azar, the cutaneous, and the mucocutaneous types. It's a mucocutaneous form which is particularly seen in the upper respiratory tract, where you have this nose, mouth, and throat. Today, most cases are from South America and from Africa, Ethiopia, and Algeria. Transmission is by the female sandfly, the phlebotomine sandfly. And today is again one of the diseases aggravated by HIV. Diagnosis occurs by clinical features and parasitological diagnosis. And the treatment is by antimalarials and by antifungals.
Hello.
Syphilis is
Kirti, I have a couple of observations. One is, of course, on my doctor, and another is, of course, not my doctor, but just an opinion. Because on second day,
please mute yourself.
Spirochete caused the syphilis is caused by spirochetes, as we all know. Treponema is the organism which causes it. Here, as I said already, it mainly affects the bony nasal septum. Unlike tuberculosis, it affects the cartilage. And the other non-venereal type, which is known as the yaws, also seen, particularly in some of the tribal areas in India. It's seen in the Todas and the Nilgiris. It's also seen in parts of the tribal areas in Chhattisgarh and so on. So these are areas where you have select groups of people where they have yaws, which is non-venereal. Sarcoidosis is a unknown etiology, and only a small proportion, less than 5%, affects the nasal cavities. Sinonasal sarcoidosis. Etiology, we don't know the etiology. It's thought to be an immunological response. So an unidentified antigen may be infectious. We don't know. It's all conjecture. Typically, facial pain and hyposmia may be seen. And probably skin appearance or the granular appearance of the nasal mucosa. Ulceration, crusting, adhesions, perforation of the anterior nasal septum. Again, this is cartilaginous, which is mainly involved. And discoloration of the skin, overlying skin, which is known as a lupus. Classically septal perforation, and you see the strawberry appearance of the skin. Steroids mainly, and then supportive therapy with nasal brushing. Surgery, very, very limited role. The other interesting condition, perhaps the most important non-infective condition, what is is vaginous granulomatosis, which is today known as granulomatosis with polyangiitis. Typically, as the name involves, it's a condition which affects the small vessels. And it's a strong association with ANCA or anti-neutrophilic cytoplasmic antibodies. It's a necrotizing vasculitis. So remember that it's a necrotizing vasculitis and affects the small and medium-sized vessels. It typically affects the nose and sinuses, where it involves in most patients, 80% of patients, case of discharge and destruction of the septum and nerves. So here you see this destruction of the septum, involvement of the nasal. The initial symptoms such as irritation, epistaxis, biliary effusion due to tubal blockage is not uncommon. You may see that and may need drainage with tympanocentesis. Oral cavity also may be involved with bone resorption, mouth ulcers, multiple mouth ulcers, saddling of the nose, septal perforations in late stage, and interestingly, it can also cause tracheal and subglottic stenosis. Kidney is one of the very important organs affected. Usually CKD, chronic kidney disease, rapidly progressing long-run affairs. 75% of patients. One of the most common causes of mortality in these patients. In lung, it produces coin lesions in areas of cavity formation similar to tuberculosis and may also present with hemoptysis. CNS, very, very rare sensory neuropathy. Thought to be autoimmune associated with anti-neutrophilic cytoplasmic antibodies. And diagnosis is by demonstrating ANCA positivity in more than 90% of patients. Renal biopsy if kidney is involved, more for prognostication, and very, very rare lung biopsy. The management in majority of cases which are just mild to moderate, it is corticosteroids, cytotoxicals like methotrexate. But in more aggressive forms, rituximab and cyclophosphamide, very high dose steroids are used. Other supportive therapy and occasionally DCR for AP4 in some patients. Tympanocentesis is already mentioned earlier. Primary atrophic rhinitis is a debilitating chronic disease, progressive mucosal atrophy, where there's widespread destruction of the nasal mucosa, widening of the nasal cavities, formation of viscid secretions, bright pus, and characteristic odor or fetor, which is known as roseta. And the normal respiratory epithelium undergoes a metaplasia to a cuboid or a stratified stem cell, and with atrophy of the cilia and submucosal glands. And there are secondary bacterial infections responsible for the odor, and the patient has anosmia. But because of the very bad smell will be apparent to the others, but to himself he won't know. Hence is known as merciful anosmia. There are two types. Type 1 is more common, which is due to the arterial or the arteriolar involvement, known as endarteritis obliterans, periarteritis. And here the second type is less common, is secondary atrophic rhinitis, following infection and solve, extensive surgery, the capillary vasodilatation, more venous. So you see the typical crusting, and the management is usually by, as I said, you may have perforation, in this case, saddling of the nose also. And management is usually by repeated saline douche and topical antibiotics. Surgical management, today the most popular operation is Young's operation, where you have the closure of the nasal vestibule. So you can see that here, this is the Young's procedure, where the vestibule is closed. Nasal myiasis, finally, is known as PNASH. Areas where it can complicate atrophic rhinitis also, where there's a putrefied nasal debris inside, which is not attended to. The foul smell attracts flies of the genus Chrysomia, and you have these maggots which happen inside the nose. They're very aggressive. They can cause palatal perforation in patients. The flies lay the eggs hatch into larvae known as maggots. These hundreds of maggots may infest the nasal cavities, eat away the soft tissue. They may create tunneling of the soft tissue and cause extensive bone disturbance. Sometimes it may even tunnel into the brain and cause terrible complications with death. So to conclude, granulomatous diseases represents an important but neglected group of diseases, significant morbidity and even mortality. And anyone who comes with a blood-stained nasal discharge, crusting the nose, should be thought to have a granulomatous disease undisclosed. Early diagnosis is very, very crucial, and you need to be aware of the condition to be able to diagnose and avoid a more severe system. Thank you very much.
Dr. Raji?
Somebody is okay. And the video is stopped by host, so no problem. So no problem. So I think this is a wonderful lecture. So I think your 45 minutes have rewinded my 25 years of ENT. Please, host, please open my video. Something is there.
Vimlesh?
So there are a few questions are there. I think they are wonderful lectures. I think everything been covered so far. Regarding the rhinosporosis, few questions are there. Then I will ask my questions later on. There's Satyaprabha from Guwahati. They're asking if Dapsone can be tried in rhinosporosis, though it is from protozoa. So should it be given after surgery in all the cases?
Dapsone and rhinosporosis.
Yes.
No, there's no evidence for it. Actually, initially there was an article from Systematic College Bello claiming that it showed benefit, but subsequent double-blind studies have shown it has no benefit whatsoever. So Dapsone in rhinosporidium has no effect.
Okay, sir. Even after post surgery also.
Post or anything at all, it's just placebo.
Same question by Sachit Anandam. Dr. Prakash Munka is asking, laser for rhinosporosis overkill? Is the laser surgery for rhinosporosis overkill? Simple excision with cauterization or
No, it's not overkill. It's not overkill at all. It is underkill. The reason why you don't want to do excision is, as I already said, you can easily seedle the seeding of the spores is very highly infectious. So if you operate with instruments like cautery and touch, you have a very high chance of seeding areas which are not involved initially. So laser is not overkill; it's a mandatory. In fact, today, I would say it is absolutely the bottom line.
Okay, sir. And Dr. Anand from Sonipat, what is the significance of medical management in rhinosporosis?
Nothing. No, zero. Zilch.
So regarding the aspergillosis and mucormycosis, suppose we get the patient with aspergillosis, diagnosed case of aspergillosis by biopsy, and so would you go for medical management first, or would you go for the surgery? And if you're going to surgery, then what?
Very good question. Very good question. You see, a lot depends on what type of aspergillosis it is. If it's an allergic fungal sinusitis, it's a very, very mild form of disease where there's a very intense post-response, immune response. So there, your idea is to clear the polyps, open out the sinuses, remove the fungal mucin, so that your anti-allergic medication, particularly corticosteroid sprays, will reach the area. And remember, oxygen, these are all, obligatory anaerobes. So oxygen itself is toxic for the fungus. If you nicely breathe, that air itself is toxic. Oxygen is toxic for the fungus. So, but the idea is that oxygen should reach that area. So, the idea of clearing the disease, polyps, clearing the fungal mucin, opening out the sinuses, so that the fungus can be no longer present there. It drains away fungal mucin, and your oxygen reaches there. Your drugs also reach there. That's all. A very aggressive disease like invasive fungal sinusitis, where it is going intracranially, intracerebrally, is across the dura and so on. They said there you have a role for systemic antifungals like liposomal amphotericin.
Okay, so
2.5 to 3 grams.
Which antifungal you recommend for that? Aspergillosis post-op?
Only see the systemic antifungals. The most important is liposomal amphotericin. And of the oral antifungals, itraconazole and posaconazole. These are the two drugs which will act. Things like fluconazole and all that won't work. So itraconazole and posaconazole are the two oral antifungals.
Okay.
But they're very weak.
So any role of surgery in leprosy cases? And suppose when you recommend surgery, suppose when you recommend surgery,
there is a role for surgery in leprosy, particularly reconstructive surgery. A lot of
when you recommend this reconstruction after this?
After the medical management is over, and once the patient is no longer infectious, then that's when we do the reconstructive. So I have myself done a lot of reconstructive work. for these patients. They do very well because don't forget it's a very ugly deformity. Sadly, one of the most very ugly deformity, and it's very easily corrected. So it's a big change for them. So once the disease is cured, they come to you and then you do the surgery.
Okay, sir. I think the time is almost 8, so we can switch on to.
One question I'd like to ask Dr. Mohan.
Yes, sir. Yes.
Mohan, in these, we all come across these cases of recurrent allergic fungal sinusitis. So these you've operated, you've widened the ostia, you've drained everything, but they keep coming back. So do you think there's any role of itraconazole in these recurrent fungal sinus cases?
It's a very interesting question. Samir, I don't think the answer is still out. There's a very important paper, seminal paper by a husband and wife team known as Mabry and Mabry. They did a lot of work on the role of systemic antifungals in allergic fungal sinusitis, and they concluded by very, very good double-blind study that there is a limited role in the first few months after surgery. If you add it on, then there is a slightly better long-term prognosis. But not many people do it. It's not fully accepted everywhere. So general idea is that we clear the fungus, we put them on steroids and follow them up repeatedly, regular. I think the crux is periodic, regular follow-up, and it has to be for many, many years to make sure that they come out of it. In our center, we give them about 15 to 20 days of antifungals, oral itraconazole. The logic being that you're reducing the antigen load in this way.
One more question. Yeah. Can I ask one more question, sir?
Yeah, sure.
In when you recommend for the young operations in atopic rhinitis?
Yeah. In fact, it's it's only operation which really works. So what you do is you have to endoscopically go in and clear all the disease there, infect the material, make sure the sinuses are usually very small and atrophic, so you have to clear all those areas. And then once you've done a nice irrigation and wash, then you reduce the nasal vestibule. Ideally, you have bilateral. One side you completely close, one side you leave a small opening, and then you follow them up to that with a very fine endoscope just to make sure that
Raju logged in. Raju,
and then it can once you feel it's fully reversed, you open it.
Okay, sir.
So,
and
how much time it takes to?
એને click કરવું છે તું video.
Usually after young, it takes about 1.5 to 2 years for the regeneration of the mucosa. And usually it will be patchy, but still it takes 1.5
કરી જ ના શકું, આપણે લોકો કરી જ ના શકીએ. It's open to all, ભાઈ મારા.
So the big compliment from Dr. Mohan Ramesh Rohiwal and so many people are there complimented for this wonderful lecture. So much being reminded because in our ENT practice we just don't regularly. So I think what we should
know. Topic for older people, yes.
No, sir.
Do you use oriconazole in invasive aspergillosis?
Yes, actually oriconazole has a role, but it's been shown to be effective. In a lot of studies. In fact, it's also been used it also. The only thing about oriconazole is a cost. It's a little more expensive than so, and between itraconazole and oriconazole, there's not been any great difference in performance. So most people prefer to use itraconazole because it's cheaper than oriconazole. But oriconazole, yes, it has effect on the.
So in mucormycosis, along with IV amphotericin, do you advise local douching with amphotericin?
Yes. What we do is we use liposomal amphotericin for intravenous, but for local douching, you just use simple amphotericin. It's cheaper. 50 milligram ampules are broken into 50 ml of saline, and then you can use it for ask the patient to wash the nose twice a day. So that's
So when do you end the therapy? Like it is you take 2 consecutive biopsies.
The total dose cannot exceed 3 grams of That's what the toxic dose. So generally 2.5 grams, maximum 3 grams.
Thank you, sir.
One question from Dr. Satyaprabha again. Like nasal tuberculosis, it is not uncommon, sir. We are getting cases.
Yeah.
So again, and sometimes we don't get AFV in that culture. So are we eligible to give ATT in those cases, or
Yeah, the organ is based absolutely right. It's possibacillary. You won't get too many carcinoma showing the bacillus, because generally, remember, bone and joint tuberculosis does not have many bacteria. Whether it's even temporal bone, the same story. So PCR is the tool which will help you with the diagnosis. You can get handled today. It's available everywhere. So PCR for tuberculosis is the one best you can do. But if you have very strong clinical suspicion, and if you are not shown by pathology or histology, you not had a PCR, start anti-tuberculosis treatment, because there's nothing wrong in that. In our country, I think we have a clinician who's senior, who's got very strong infectious suspicion. You would take that as a very important diagnostic parameter.
Thank you, sir.
Thank you.
Sorry, Pritam, we have taken your time.
No, that's not fair.
Thank you, Mohan sir, for your lucid talk. We all enjoyed as usual. For the past 25 years, I've been listening, and still we feel like listening to you more and more. Thank you, Mohan sir. And thank you, Rajiv, for moderating this session.
Thank you, ma'am. Thank you.
And for the next session, we have the talk by Dr. Preetham. Our moderator is Dr. Vinod. Actually, he is Associate Secretary of the National AOI 2020, and his academic position is Associate Professor of the Cooper Hospital. And his main interest is in otology and rhinology, with specific interest in endoscopic ear surgery. Over to you, Vinod, to carry this session forward.
Thank you, madam. When we all from AO team, without taking too much time, I like to introduce our speaker, Dr. Preetham Stapeti, who is currently holding the post of additional professor in All India Institute of Medical Science, Bhubaneswar, Odisha. He has done his Master of Surgery from the prestigious Premier Institute of India, that is AIIMS Delhi. He is also holding Matter of National Board, MNAM degrees in otology. He has done a lot of higher medical training across India and abroad. Most notable, which is work on implantable ingates conducted at Academy of Hearing Implant Surgery in Medell, Australia. Cochlear implant surgical shop at Cochlear Institute in Sydney, Australia. He has done observation in implant otology at Singapore General Hospital under Dr. Professor Barney Tan. He has a lot of national and international presentations, meetings as a speaker, as a panelist, as a moderator. There are non-ending list. So I'll highlight the most important things in that part. He has presented in Skull's annual meeting of North American Skull Society in California, specifically topics of skull-based lesions, endoscopic management, and lateral skull management. He is also moderator and panelist in American Academy of Otolaryngology and Head Surgery annual meeting in New Orleans, USA. Topics are inner malformations and pediatric vein stenosis. He is also an invited speaker for fifth World Congress in emerging nationals in cochlear implant surgery, Cairo, Egypt. He is invited as a speaker, faculty, trainer in more than 20 national workshops, conferences, and teaching activities. He has numerous research papers as ongoing as completed research in the field otology, rhinology, specifically in the zone of India, Odisha region, along with India Council of Medical Research, ongoing as multiple accredited projects. He has numerous national and international publications across all topics: ENT, neck surgery, medications, and he has recently developed an app called as in hearing screening test app, which is available on Android Play Store freely for screening of adult and pediatric populations. Without taking too much time, I will like to say thank you for our previous speaker, Mohan Kameshwar sir, and ask our friend speaker, Dr. Pitam Singh, to start with his topic, that is Epistaxis, what, when, and how, and which is the most common topic come across ENT surgeons and causes difficulty in their own sleep and their daily activities. Thank you. Over to you, sir.
Yeah, thank you, Dr. Vinod. It was very nice of you. I would just want to thank Dr. Bharati ma'am and Samir sir for providing this opportunity, and Dr. Vinod for giving a nice introduction. I really don't deserve so many words. So without wasting any time, I would start sharing my screen and start the presentation. Dr. Vinod, is my screen visible? It's all good?
Yes. Yeah.
Yes, good.
Yes. Okay. Thank you. So today we are going to discuss about epistaxis. It's a very, very common topic. It's a very common thing that you encounter, and then we all feel that it's something that we can do it day in and day out, and we'll never have any complications. So my talk is basically to talk about three things. You're going to talk about what is epistaxis? What are you really expecting from epistaxis? From a very clinical point of view, we're going to learn what is the anatomy, which is very essential for us. When do you need to consider an intervention, and how would you consider your intervention? So what are the options for your intervention? So my talk is basically what, when, and how. So simple epistaxis like this, piece of cake, any one of us would take care of this. Sometimes the patient even itself comes down and his epistaxis is taken care of. Now the problem comes in when you have something like this. And then in these scenarios, if you go wrong in somewhere, either your diagnosis or in your management, you could mess up the big occasion and then you would end up in trouble. So one of the age-old technique which still works wonderfully well with the test of time is the Hippocratic technique. So all you need to do is just pinch the nose well, and then you would have to bend forward and you're good and your bleeding is going to stop. The only thing you need to remember is just squeeze the nose for 20 minutes, because 20 minutes is the time that it takes for the platelet plug to form. And more than 90% of your cases are going to get cured by this. Now, what is a significant epistaxis? So, for example, when you're just fiddling around your, like here, I'm doing an medial maxillectomy, and you're just fiddling around and suddenly you have a bleeder. So it is not mandatory that your bleeder of this sort is going to only come from an internal carotid artery. Here it is from the internal maxillary artery, and this could already cause a trouble for you. So this is quite a significant epistaxis. So, for example, we had this case where you would unknowingly encounter an internal maxillary artery aneurysm right over here. So these are cases which would need your expertise and you need to suspect them. Okay. So what is most important is the blood supply. We know that the nose has huge amount of blood supply. It is very well supplied. So it has cross connection, and it has the internal carotid artery and the external carotid artery anastomosis. It's one of those locations. So as I put it over here, you have basically two important circulations over there. So you have supply from the external carotid artery, which is the bigger one. That's because external carotid artery is the major supply. And then you have your internal carotid artery, which is a smaller one, because sometimes it can be the branches of internal carotid artery supplying the nose can be absent. So this is an age-old table. Just to reiterate it, the facial artery and the maxillary artery are the most important. So you would have a superior labial artery from the facial artery, which is supplying the septum. Then you have the ala being supplied by the lateral nasal artery, and then the ascending palatine artery again giving the floor. Then from the maxillary artery, you have the greater palatine artery coming through the incisive foramen, and then the spinopalatin artery with its branches. The internal carotid artery goes up and gives the ophthalmic artery, from where you will have these two branches, the anterior ethmoidal artery and the posterior ethmoidal artery. Now, when you consider here, so one of the most important supply from the nose, when you consider this septum also, is that the external carotid artery comes down to the spinopalatin foramen, and then you have its branches through the posterior septal branch, and then it goes around and gives you supply. And then if you see the internal carotid artery, you would see that it goes right up, it gives the ophthalmic artery, and from there you have the anterior ethmoidal artery and you have the posterior ethmoidal artery. And then in around 20% of the cases, you would have a middle ethmoidal artery sometimes present, and that sometimes could lead to an unexpected skull-based bleeding that you could encounter in your advanced surgery. So this is what is something that you need to know. And for the lateral wall, the most important is always the spinopalatin artery, the lateral branch which is there, which divides and gives supply to your turbinates over there, predominantly the inferior and the middle turbinate. So just posterolateral to it, it is submucosal, and once it enters into the inside the substance of the turbinates, it becomes, or it goes in the osseous channel. So which I'm going to show you as we go further. So this is one of the most commonest area where you will have bleeding. We all know that it's known as the Little's area or the Kisselbach's plexus. So you have the superior labial artery, which is coming from the facial. Then you have the greater palatine artery. Then you would have the Spinopalatin Artery branches and the anterethmoidal artery branches. And then you would have this arterial plexus over there. And then they bleed there. Why does it bleed? Because that's most anterior. It's the area where the maximum turbulence of air occurs. And that's the area which goes dry. That's the area which is exposed to nasal picking. And that's the area where maximum trauma can occur. And so majority of your bleeding is always going to be from this particular area. So this is a very, very important slide that you want to look at. So when you consider the Spinopalatine foramen through which your Spinopalatin artery comes in. So now there are multiple variations which can occur. So this is the septum. So this is the lateral wall again. So here, before the maxillary artery gives the Spinopalatin artery, so before coming in, it can divide, it can come out and then divide, or it can give out multiple branches from here. So let's consider the most commonest presentation where the Spinopalatin artery is coming out and then it is dividing. Where does it divide? It divides into one branch, which is the posteroseptal, which is again very important for the nasoseptal flap or the Haddard's flap that we do. And the other one is the posterolateral rami, which gives branches to the inferior turbinate and the middle turbinate. Now, the most important point here that you need to remember is when this artery comes and goes across and comes to the septum, it passes through the anterior face of the sphenoid just below the sphenoid opening or at the upper rim of the choana. Now, this video is very vital because this is again a pituitary case where we were called in for bleeding, and you more often than not would see the bleeding from the anterior face of the sphenoid, from where this particular artery was passing. So in majority of us who are associated with sphenoid surgery, who are associated with pituitary surgery or transsphenoidal surgeries, one of the commonest cause of postoperative bleeding is not an internal carotid artery, but the Spinopalatin artery, which is passing across the anterior face of sphenoid and going on into the septum. So this is very, very important thing that you need to keep in your mind. And when you're doing these surgeries, you need to specifically cauterize this area where the artery is passing, and then you would not have your postoperative epistaxis coming to you. So this is again one point that I was telling you. This is a case where we had operated on an inferior turbinate squamous cell carcinoma. But then the point here is not the pathology. The point here is how does the epistaxis occur when you do the turbinate surgery. So here you can see that we're going to drill over the turbinate tissue over there. But as we drill, you would see that there is a bleeding which occurs from the bone. It is the osseous canals which are there inside the turbinate, and through inside which you would start having bleeding. So this bleeding cannot be directly taken care of by your bipolar cautery. So you need to either drill it or you need to go in and use a monopolar cautery over there, which again carries a bit of risk because of the orbit being there. So this is something that I was talking about, that they go inside osseous canals once they are inside the turbinate, and that's the reason why your turbinate surgeries tend to bleed. So considering the internal carotid artery, you have two main branches. As I told you, the anterethmoidal artery, which passes below the superior oblique muscle, and the posterethmoidal artery, which passes above the superior oblique muscle. There are two important points here. One, both of them come from lateral to medial, and both of them come from posterior to anterior. Majority of your time, you would not encounter them, but all days are not yours, and if you have a low-lying dura or you have a supraethmoidal cell, then you would encounter them. So here in this scan, you would see that you have a Canadian nipple from where the ethmoidal artery comes outside the orbit, and then it goes into the roof. So this is something that you need to keep in mind. And sometimes you would also encounter the middle ethmoidal artery to the ethmoidal foramen, middle ethmoidal foramen over here. And that should always be kept in mind while doing your skull-base surgery. Now, as I told you, not all days are yours, and sometime or the other, you would end up with a complication. That is, your anterethmoidal artery would retract into your orbit and you would have a retroorbital hematoma. So you would obviously have seen what I have seen as Stamberger videos, do a lateral canthotomy and decompress the eye and then endoscopically go and cauterize the anterethmoidal artery. But once it retracts into the orbit, it's going to be difficult. Or else you're doing pediatric cases where the endoscopic anatomy is very, very difficult. Then all you need to do is you need to go in and be sure of your anatomy to cauterize the anterethmoidal artery and the posterior ethmoidal artery. So here is the lacrimal bone, the anterior lacrimal crest and the posterior lacrimal crest, and it is the ethmoidal bone right there. And this is the frontoethmoidal sutures. So the relationship is from the anterior lacrimal crest, the anterior ethmoidal artery is 24 millimeter. From there, the posterior ethmoidal artery is 12 millimeter behind the anterior ethmoidal artery, and the optic canal behind the posterior ethmoidal artery is around 6 millimeter. So these are quite close. So all you need to do is pull the orbit with the periorbital laterally, and then you would see these arteries over there coming in front of you, and you need to cauterize them. And if you see very carefully, you would see that there's a frontoethmoidal sutures and they lie just above the frontoethmoidal suture. So you would sometime or the other would need to take care of these arteries externally, and this anatomy would help you immensely in that. So in the nose per se, there are two plexus that you have. One little area we have already discussed. The other one, which is talked about or is a controversial thing, is a Woodrus Plexus. Some textbooks tell you that Woodrus Plexus is an arterial plexus between the Spinopalatin Artery and the ascending pharyngeal artery, and some textbooks would outrightly tell you that it's a venous plexus. So we are not sure as of it, but it lies on the lateral wall just behind where the inferior turbinate ends, and that's an important plexus. This is where you see it, but still this is not the commonest area which bleeds. The commonest plexus that bleeds is always the little's area. So this is another important anatomical aspect that you need to remember is rebleeding. So for example, you ask your radiologist, who is an interventional radiologist who is doing embolization of your arteries. He would definitely tell you one thing, that whenever they're going to do an embolization, say of the maxillary artery, they go in and embolize the facial artery, because there are huge collaterals from the facial artery. And even if you embolize the maxillary artery, you would still have some rebleeding occurring from the facial artery. So even if you have ligated the arteries and there is bleeding, always consider facial artery is one of the important cause. So the venous drainage, usually they go along as anywhere in the body. They go along with the arteries, but then you would have the only exception is the periarterial venous cuff, which is there in the intraosseous portion of the inferior and middle turbinates. And you would anteriorly, they go into the superior labial and greater palatine vein, then they go into the facial vein, and then the external jugular vein. Posteriorly, they go into the spinopalatine foramen, pterygoid venous plexus, and the internal jugular vein. The important thing in pediatric age group is just 2 millimeter behind the columella, you have the retrocolumella vein. And if some kid has recurrent rhinorrhea or something, then they would have bleeding from this retrocolumnar vein right there. And then if you consider the final picture, then they would all be draining into the external jugular vein or the internal jugular vein. And this is all about the venous drainage. So now, with the basic idea of the anatomy, let's think about classifying your epistaxis. So based on age, we would classify it as an adult or a childhood epistaxis, more than 16, less than 16, because the causes change. A primary is when the cause is not known. That's what your major epistaxis conditions would be. And secondary, when your cause is known. For example, somebody is taking a medication, somebody has a systemic disease, somebody has underwent a surgery, or else it could be an anterior or a posterior epistaxis. Now, anterior epistaxis is something which is anterior to the piriform aperture. So any structure anterior to the piriform aperture is bleeding, then that would be anterior. And any structure which bleeds posterior to the piriform aperture is a posterior epistaxis. Not necessary that the anterior epistaxis, the blood comes out through the nares anteriorly and when it goes back into the posteriorly. And the other one, which is a little bit controversial and not described in all the papers, is the minor or the major. Minor and major cannot be quantified just because each and every person is different, and the amount of blood that one person loses might be minor for one but major for the other. For an 80 kg well-built male, 100 ml would not matter, but that would mean life and death for a neonate or for an infant or for a kid. So that's why. So any epistaxis that causes a disruption of the vitals of that particular person should be considered major, and they should be taken care of very meticulously. So an age-old slide, but very important. The septum, both anteriorly and posterior epistaxis taken together, septum is universally the most common site where you would have an site of bleeding. And then in 6 to 7% of the cases, you would not be able to identify the site of bleeding. So that's something which is hidden to us. So etiology wise, I'm not going to bore you with going with the whole list that's out here. So I'm going to just talk about certain important factors which are there. So one is demographic. As in with other diseases, you would find it typically in males. You would find it typically in very young age or in older age. It's seen in winter months or in cold areas where there is a lot of dryness, which is associated. There's a circadian rhythm to it, and it is somewhat similar to the subarachnoid hemorrhage, usually seen early in the mornings or in the evenings. Then obviously your medications like NSAIDs are associated because that impairs your clotting ability. And then alcohol is something that has been implicated. Now, alcohol is not per se causing any platelet dysfunction or any decrease in platelet count, but it's been seen in studies. European papers talk about history of having alcohol intake 24 hours prior to the episode. So within 24 hours prior to the epistaxis episodes, people have had alcohol ingestion, and that's something there. And something which is very alarming is the lack of hypertension and septal abnormalities as a significant cause or a significant association. They are always present, but then we don't know that's just the epistaxis causing the hypertension or the septal abnormalities just being so common. It's been there, and then there is no definitive association which is there. But then for our Indian scenario, where the control of hypertension is still not perfect, people are still not going to the hospitals daily, are not still are getting screened daily. Hypertension and septal abnormalities still are a major concern for us, and we would always keep them in mind while managing these patients. So this is one of a clinical example from which we learned a lot, or I learned a lot. So this is this 12-year-old small kid with history of tonsillitis and fever. She comes in with a scan, and then you see that there is something over there. And then we thought that it's just a tonsillar abscess, but the only catch in the history was that she had few bouts of oral bleed that occurred. And then when we examined her, we found this swelling in the neck. And then as a routine, chalo, let's get a contrast enhanced scan done. And when you get a contrast enhanced scan done, then what you see is a mycotic internal carotid artery aneurysm present right over there. So it's a pseudoaneurysm which is present over there. And you know pretty well what will happen if you would have nicked that area. So this case taught us a lot. So this case teaches us that you need to get your contrast scan right in. So this is yet another example where a patient presented with bleeding, massive bleeding. He had a nasal mass, but then we did our contrast scans and we found that he had an aneurysm, took care of the aneurysm, and then we took a biopsy and it turned out to be a lymphoma in the nasal cavity. So this lymphoma eroded the artery right there and it formed a pseudoaneurysm and it bled. So these sort of cases would deteriorate the fact that you need to get your radiology with contrast in case of any doubt, because otherwise you would be in deep trouble. So these warning bleeds are something that you need to keep in your mind. They're like a ticking time bomb, and warning bleeds should not be taken lightly. So you can always err on the side of over evaluation rather than under evaluation. So when you talk about evaluation, you would have to look for the vitals, resuscitate, and the traditional ABC is there, which you always have to take care that your trauma unit would do, or if you head the trauma unit, you would have to do. So history, hematological evaluation, systemic evaluation, radiology. These are all going through your mind when you're taking care of the patient. But then the prime and most important thing that you need to do before you do any of these things is stop the bleed. Because if the patient is bleeding, you are not going to get any of these things. How do you stop the bleed? So for the management of the bleeding, you need to take either of these approaches. Are you able to go for a direct method where you visualize and take care? Or are you going to go for a indirect method where you primarily want to stop the bleeding to buy you time to prevent patient from deteriorating, and then go in and do what best you can do for the patient? So indirect methods, majorly what we use in our scenario is topical vasoconstrictors, pinching of the Hippocratic technique, because septum and little's area is the one that is there. You pinch put your head down. 20 minutes is something that you need to tell your patients, because if you don't tell 20 minutes, we tend to leave it out, try to see if the bleeding has stopped, then it will not work. So 20 minutes is when they need to give pressure. Gentle inspiration is something that majority of your patients would do. It just induces a little bit of dryness over there, induces a little bit of clotting. It stops. Then obviously you have topical moisturizers, humidification, and all these indirect methods work well. And majority of these bleeds are controlled by the time they come to you. The indirect methods are using your packs. You can use your traditional packs, Epistats if available, yes. You can use your Merosils, you can use your Rapid Rhinos, whatever is available to you and whatever you're comfortable with. And the traditional tonsillar packs for your posternasal packing is something that we tend to use, and then we can go on and use them. So these are the options that you have for indirectly controlling your bleed that are occurring. So what are the newer things that are available to us? So usually what is known as cellulose, which is the oxidized regenerated cellulose, or the Surgicel, can be placed. You could use gel foam or the gelatin sponge. I'm taking these company names because they are something which are very common. I just want to I want to say that we don't have anything with these companies. It's just that they are very commonly used as a terminology in our country. So then we can have a fibrin glue, and then we have the flow seal or the patented thrombin particles with gelatin matrix. All these things can be utilized to stop your bleed, either during a surgery or just as a sole or a solitary presentation of epistaxis. So now, considering yourself as a superpower or a superhero. Okay, all of us are superheroes in the COVID era. We are all COVID warriors. So you are a warrior. So anybody of us who is taking care of emergency patients, you need to remember that you're a warrior, and every warrior has their weapons. So what are your weapons? So these weapons are something with which you would have to take care of your epistaxis patients. So you would need your Tilly's forceps. Yes. You would need a paraffin gauze or a simple gelonate that you call. So this is used for minimal bleeds, anteriorly placed bleeds. You just place it in. It causes minimal trauma to the septum or the lateral nasal wall, and your bleeds are controlled well. For heavier bleeds, you obviously have your ribbon gauze. Use betadine ointment. Avoid paraffin because it causes pneumonia. And then obviously you have your Foley's catheter. So if you see here, we're using a Foley's catheter, 8 to 12, depending on the size of the or the age of the patient, and then the umbilical clamp. So these are the things that you have. Then I would say 99% of your bleeds would be taken care of. So these are your superhero weapons that you have, and you need to control all your bleeds with this. So what is important here is when you're using an umbilical clamp, try putting a gauze piece, because alar necrosis is something that occurs very commonly, and it's not at all an uncommon complication. You can encounter it, and all you need to do is put to 5 to 10 ml of saline here, and then pull this forward, and your posterior bleed also stops. So then you have the time, once you have stopped the bleeding, to go with the history, to do a hematological evaluation, to do a thorough systemic evaluation, get your medicine colleagues and other colleagues joining in, and then go for your radiology. And in radiology over here, if you are planning for a radiology in an epistaxis patient, that means that your epistaxis is quite significant, and then always get a contrast enhanced scan. Be it an MRI, be it a CT scan, always get a contrast enhanced scan, because that is very, very vital. Otherwise, as I showed you in some of the examples, you would miss out a lot of information, and that could be catastrophic for you. So if you see systemically, there are many, many causes which can all be taken care of by stopping those drugs. For example, if somebody is on anticoagulation, or just giving platelet transfusion, or then giving FFPs, giving vitamin K. So these are some things that you need to rule out. And then if you find some systemic cause, then treat them, and then take out your pack. Because if you take out your pack earlier before treating these conditions, then you would end up with trouble. So these are certain conditions that are commonly associated or are commonly encountered, and you need to take care of these conditions while treating an epistaxis, because these are the primary causes for you. Direct method is always the gold standard method. You either, with the advent of fiber optics, you can go in and evaluate with your fiber optic right there in the OPD or in the emergency. And then when you take them to the operation theater or to your minor OT, you can put in your rigid endoscope in, identify where it is. And then if it's a small one, take silver nitrate, dicarboxylic acid, whatever is available with you. Or else if you have a bipolar cautery, that's the best. And then cauterize that area, and bang, you are done. So you can just use some oxidized cellulose over there, and then you just keep it, and then you're good to go. You wouldn't even require a nasal pack. So these are certain therapies that can be tried, that have been tried and have worked with few and have not worked with few. Now, what is the role of a warm saline irrigation? So this is something of a paradoxical treatment. There are two theories which go over here. So when you irrigate with warm saline irrigation, they say there is vasodilatation, there is mucosal thickening, or the mucosa gets swollen up, and then there is a tamponade effect. And then another theory is that it instigates the extrinsic pathway, and then your clotting occurs earlier. So there are again some things which are given very routinely many places. We in our institute do not give it as a routine, but then many institutes give it. So tranexamic acid and then epsilon aminocaproic acid, antifibrinolytic agents. So these are something which are given. I've gone through the literature. Nobody says against it, but there's a meta-analysis right on done in 2017 which talks about benefit in 2 randomized controlled trials of using topical tranexamic acid, but they don't talk about IV tranexamic acid. But then it's up to you. If you're using it, then obviously it's good. But the only thing that you need to remember is the patient should not be a cardiac patient or should not have had an ischemic disease anytime. So this is an interesting technique. So this is something that we also tend to do before our surgeries, but not specifically for epistaxis. So major of the time, you know that the Spinopalatin Artery is a branch of the internal maxillary artery that comes through the pterygopalatine fossa. So you palpate the greater palatine foramen, which is opposite the second molar and right midway between the midline and here. And then you take a 25 gauge needle and bend it at 25 millimeter. Now the science of bending it at 25 millimeter is that this greater palatine foramen is 18 millimeter and the soft tissue that's there is around 7. So approximately it's 25 millimeter in length, and anything lesser than that would not deliver your liquid over there. So you can take plain saline, you can take adrenaline with xylocaine and inject it there. Now what it does, it creates a tamponade in the pterygopalatine fossa by compressing the artery, and then your bleeding can be definitely less. So this is something that we can do in our preoperatively in our surgeries of FES also, because this decreases the bleeding in a significant way. So what are the surgical managements that we have? So you have ligation techniques. Obviously it's vessels, and the vessels are supplying. You need to ligate the vessels. And then the age-old technique where you just have to elevate the septal flaps and place them back, because that will interrupt the blood supply to the septum, which is the commonest site of epistaxis. Now, when you consider ligation techniques, there is a protocol, there is a step ladder pattern which you have to follow. The most commonest vessel that is implicated is always the Spinopalatin artery. So you need to take care of it first. The second step is the internal maxillary artery, because it can either divide and come out into the nasal cavity with multiple branches. The Spinopalatin artery might come out in 2 or 3 branches behind the main Spinopalatin artery, so you might miss it. So after Spinopalatin artery ligation, you have internal maxillary artery ligation. Then comes the external carotid artery, which is rarely done nowadays. And then you would have the anterior and posterior ethmoidal artery. Now, why anterior and posterior ethmoidal artery are lower down? The simple reason being that in 80% of the cases, you would have anterior ethmoidal artery, but in 20% cases, even the anterior ethmoidal artery, which is the major supply, could be absent. Posterior ethmoidal artery can always be absent in around 30 to 40% of the cases. So it's not mandatory that you would have these arteries. And we know that internal carotid artery branches form a lesser part of the circulation. So this is what you would have to remember. And this is what is the protocol that you need to follow. So regarding the Spinopalatin artery, you know that just behind the maxillary sinus opening, you need to elevate, and then you would find the Spinopalatin artery coming out of the Spinopalatin foramen right there. So what is the anatomical landmark? You would have the crista ethmoidalis, as I show you with my cursor here, and you would find it 1 millimeter behind it, and it's been there. We have a decent series, and in all our cases, it has always been there. Only difference is if you're doing a Spinopalatin artery ligation just for epistaxis, then it would be of a bigger caliber, and you can just apply your Liga clips. And for your other procedures, you can just go on and and cauterize that, and you would have good results. So here you can see the small bony projection, that is the crista ethmoidalis, and you can see as you pull the mucosa, the artery tenting over there, and then you can go in and do it. It's a very simple and straightforward procedure with literature talking about 90 to 100% success rates. And obviously few papers talk about lesser success rates, but then it works wonderfully well. So internal maxillary artery ligation is something not required usually, but we usually tend to do it in a post-op. This is a post-op angiophyreuma. Here you can see the middle cranial fossa, you can see the sphenoid and the infratemporal fossa, but this is where we have applied. So if you can see very clearly, you have an artery which is pulsating. So we have applied a liga clip right over the internal maxillary artery over there. So if you ligate your internal maxillary artery with this liga clip, then you would be good with your surgeries. You would also prevent post-operative epistaxis. Now, it's not mandatory that you do it endoscopically. Even at the beginning of the procedure, you could just go sublabially, take away the posterior wall of the maxilla, and then right there, you would find your internal maxillary artery embedded in the fat tissue over there. And with experience, you would be able to identify it and then cauterize it, and this would decrease the bleeding even in your tumor cases and other cases. Anterior ethmoidal cauterization is very, very rarely required. Now it is into vogue just because we are doing extensive skull-based procedures. Otherwise, you would not even encounter it. So there are 2 points here I want to show you. So this is the septum and this is the lateral wall. So here you're seeing me cauterizing it all through. I'm cauterizing it all through right from the orbit and to the septum. So that is very, very vital because you would not want to leave anything for chance because it can retract. So, and then when you look over here, I'm just cutting it and then pushing it down. So if you see the cut that we have made is towards the septum. It's not something that we have done towards the orbit. We need some stump of artery there near the orbit because that would prevent its recurrence. Then if it bleeds into the nose. Even if it bleeds, we don't want bleeding, but if it bleeds, let it bleed into the nose and not into the orbit where it could be catastrophic for the patient and for you. So while talking about skull base, so traditionally we endoscopically deal with midline skull base. We have an anterior, middle, and a posterior skull base. So the middle skull base is basically the sphenoid, just the planum sphenoidal and all the sphenoid and the upper clivus. And then the posterior skull base, midline skull base is the clivus and behind it. And so that's not something that we encounter here. It's usually the ICA. So we are not talking about this bleed because these bleeds are difficult to manage. And then you would need interventional radiologists to manage these there. So what we primarily encounter is anterior ethmoidal artery and the posterior ethmoidal artery, just anterior to the planum sphenoidal. So here we would need to take care of these. And in case they bleed, you should go back to that slide that I talked about, 24, 12, 6. And if you're doing your skull-based surgeries, sometime or the other, everybody of us has complications, and sometime or the other, we would have to go with an external approach and then cauterize these arteries once they are retracted in. So if you're doing extensive skull-based surgeries, for example, you're doing DARF procedures or you're doing a type 3 DARF or something. So what happens is you would then encounter the anterior ethmoidal artery, and it is better in those cases to identify it and then cauterize it or ligate it and then make sure that you have controlled that bleed. But then once you're going deep inside, say for example, you're going transsphenoidal or you're going transcribriform, in these cases, you would have to take care of them because for your exposure, they are very much required. So just for this transcribriform approach that we are doing, you need to take care of both your anterior and your posterior ethmoidal arteries. And then anything beyond it, you would need your interventional radiologist and your neurosurgeons helping you out. So that is very, very important. And then as I told you, external incisions are something that you should not shy away from. If required, open up. And external carotid artery ligation, you might not require, you should avoid. But then if you require, then you would need to open up. Obviously, this is just a representative picture. You can just do with a simple small incision anterior to the sternocleidomastoid, identify the carotid, and the carotid which is giving branches should be the external carotid artery, and then you go on and ligate it. In the present day scenario, even temporary ligation or permanent ligation of external carotid artery is not done. We would prefer going for what you call as embolization. So I'm just showing as an example that case that we managed. So it was that mycotic aneurysm that we managed with coiling. So you would ask your neuroradiologist to go transfemorally and put in your coil there, and then they can occlude it off completely, and then the embolization would work wonderfully well. And then if your ligation doesn't work, before you go for your ECA ligation or for any other major procedures, you would always ask your neuroradiologist or your interventional radiologist to look into and then embolize the things for you. So this is one condition that's to be mentioned because it's something that you would encounter and then once in your lifetime, and then you would have to be aware. So this is a condition known as hereditary hemorrhagic telangiectasia, where you will have recurrent epistaxis. It's an autosomal dominant condition. So you would have multiple telangiectatic spots, you would have AV malformations and aneurysms there. So you can use hormones like estrogen, you could use antifibrinolytic agents, you could use argon laser. But one of the procedures that's done traditionally, like as Mohan sir was mentioning, the Young's operation or the modified Young's operation for atrophic rhinitis is the septodermoplasty, where you just take away all the mucosa right over there and put in your split skin grafts over there, and you replace this mucosa with a squamous epithelium. So just to summarize, if anybody comes with epistaxis, you need to first do an ABC, do fluid resuscitation, establish an intravenous access, and then go with your evaluation. You need to suction off the clots in a controlled environment, either in your minor OT or in your main OT, and then examine and identify the source of bleeding. So once you identify the source, if it's small, bipolar or your chemical cauterization can be done, or you can use topical hemostatic agents that we spoke about. If the source is not identified, then you need to use your indirect methods of stopping the bleeding. So one of your odd cases would not respond to either of these things, and then in those cases you would need your surgery. The best is always the endoscopic spinopalatin artery ligation. That's the best. If that's not possible, then you go into the IMA, or then you go into the ECA or the anterior and posterior ethmoidal arteries, and then you would go, otherwise you would go for your angiography and embolization. Usually angiography and embolization is done when somebody has facial trauma or they have had some injuries which are occurring. So otherwise you would not usually read your angiography and embolization. And always remember that if you're ordering a scan, always go for a contrast enhanced scan. So that's it from my side. Thank you. Yeah, great. So if anybody has any questions or anything.
Thank you. It's a great talk. I think we have a few questions. Dr. Sachidanandan from Pondicherry, do triptychs help in epistaxis management? Any general practitioners prescribe for 5 to 7 days for simple little area?
Yeah, we could use it, but the literature doesn't talk about it, so I could not mention it. But these are some things that are done locally and they work wonderfully well over the years, and you can definitely go on and use it. There's nothing against it.
Okay. Second question is from Dr. Satyabrata Fukan from Guwahati. In a reduced heart rate and a reduced cardiac output, what to be used ideally in case of with the hypovolemia?
Yeah, if in case you would have to initially, obviously you would not get your blood products immediately available to you. So you obviously need to use your colloids initially, but then you should not overburden the patient because you have not assessed the cardiac status. So just look at colloids to manage the initial hypovolemia and the shock, stop the bleeding, and then get your medical colleagues in as early as you can, because you tend to manage them on your own. You would end up with trouble because you don't know what the cause is. It could be just a simple hypovolemia, or it could just be a block which is there. So you don't know what kind of block it is. So get your ECG in and then get your cardiologist or your medicine specialist in there. So that's something which is a very, very nice question to ask.
There is a nice comment from Dr. Ramasubramanian from Kolkata. That is a very illuminative lecture.
Thank you, sir. Thank you.
There is a question by Dr. Jayaprakash Reddy from Kurnool. What is the management for recurrent epistaxis from sphenoid and ethmoidal areas? I think it is question is a little bit how.
Yeah. So sir doesn't need to ask a question. He himself is a mega star in the field of ENT down south. So now, sir, for your question, if a sphenoid, as I mentioned, sir, we usually tend to have bleeding from the anterior face of sphenoid. So a spinopalatin artery ligation or cauterizing that area would work wonderfully well, unless and until it is a warning bleed which is there from the internal carotid artery, where your angiography is sort of mandatory to rule out a pseudoaneurysm. from the skull base in the ethmoidal region, you would have you should have an ethmoidal artery bleed. So that's what you commonly tend to encounter. So you should be able to identify it. If not, the external approaches is definitely good. But then even in those areas, if you're not able to go endoscopically and do it, you could always go externally and then cauterize the anterior ethmoidal artery and the posterior ethmoidal artery, and that should take care of majority of your bleeds.
Thank you, sir. There is one question by Dr. Ramesh Uval from Aurangabad. What are the indications for selective embolization, and what are the complications of embolization?
Okay. So it's a very, very wonderful question and a very nice question to have. So in selective embolization is something which is sometimes overused, because if you're using it for tumors, yes, you're using it for your angiofibroma, you're using it for a hemangiomatous lesion, it's good. But when you're doing it for your epistaxis, it always has to be your last resort. If it's your primary resort, then that's a problem, because one, you have the practical points there. If you have a pack in situ, one, your radiology will not show any mass in the nasal cavity. It's very difficult to identify. Two, there is no active bleeding going on. It's very unlikely that your angiography will reveal anything. So once you're sure that it is bleeding from some particular area, or you're looking at a major vessel bleed, which you're not able to control, then you would have the role of an embolization. Now, here, again, going for the internal carotid artery or the major artery embolization is again a big problem, because you can have complications. In the best of the hands, we have seen monoplegia occurring. In the best of the hands, we have seen blindness occurring. So if something you have to do as an intervention in the internal carotid artery, then you would have to explain these things and then take the patient up. These complications, I'm not sure how commonly they're mentioned in the literature, but I have personally seen them. And then these are something that you need to be very, very wary of.
Comments from Dr. Rajesh Jain and Dr. Prakash Munka. Very informative webinar. And I think there is no pending questions. Last question from my side. What are your suggestions of the Epistaxis management in current COVID era? Because that changed a lot of things, how to manage the surgical part. And as major of resident faculties are handling, and a lot of people turning out to be positive after the procedures, and still we don't know where we are getting infected, especially in resident category. So any suggestions?
So in the COVID era, the only sole thing that we can manage, at least in our sort of in a public sector where we have huge patient load walking in, it's really not possible to test them before you really do anything. So wearing your mask, preferably a double N95 with a surgical mask around it and a face mask and your goggles in, and then making sure that without much of hodgepodge, just go in and pack the nasal cavity, stop the bleed, and then have some time closely to then evaluate the patient. So you need to wear protection. I think the protection is the only that's preventing any sort of infection which is occurring, because if there's an epistaxis going on, there's no way in the world that you can do anything else rather than packing. So you initially used to take them in and then do an endoscopy. I think in the present day scenario, you would have to pack, wait, get them tested, and then take them up for the direct methods of endoscopy and other things.
One point from my side. So we get many cases of recurrent telangiectatic cases, hemorrhagic telangiectatic. You recommend just take out the mucosa and then put a graft, free graft. Any other option besides this? Because a graft uptake, maybe suppose it doesn't take, then chances of so many issues are there. Any rule of septoplasty with the mucosa resection or like anything?
Sir, this is the last option. As Mohan sir was telling, modified Young's operation was last option for the atrophic rhinitis. Similarly, septodermoplasty is the last option for these sort of telangiectasia. So you would use simple bipolar cauteries. You can use simple chemical cauteries, and if you have laser, then you can use the contact lasers over there and cauterize these areas. Majority of the time, these would work wonderfully well. If they don't, then the ultimate role or the last sort of the resort for you is to do a septodermoplasty. So that's something nice to know, but then that's not something that you would maybe use in your whole career, because one, the disease is such rare, and the procedure is also sort of a last resort. But yes, seniors could also.
Wonderful talk from both of you, sir.
Thank you, sir. Thank you.
So there are a few more questions. Dr. Ashim Kumar from Kolkata, role of Merocel in Merocel packs for nasal bleed management.
Yeah, bleeding management, Merocel is any day the advantage. Nowadays, you have rapid rhino, you have other hemostatic materials around the pack which you can use. They are definitely preferred above your traditional roller gauze packs that we use. The only problem with them is the availability and the cost. So if that's there as a supply in your institute, as some of the institutes have, then you are at the liberty of using them left and right. But then if you don't have it and your predominant population is of the lower strata, then it's a problem. But then they are definitely any day better because they, one, induce hemostasis, and two, they're easy to take off and atraumatic comparatively.
Can I just make a comment?
Sure, sir.
I think it's one of the best talks and episodes I've ever heard. It was wonderful, really nice, very comprehensive, very lucid, and I think you get very clear ideas. I really compliment it. It's really good, really good. Enjoy it.
Thank you very much. Thank you, sir.
Any questions, Dr. Vinod? Pending questions?
Yeah, there is one question by Dr. Abba, but I think that can be, like, can you re-explain the SPA cauterization? I think our current series of lectures will be shortly available on our AOI website. So all can access the lecture series later on of all the topics and details. And there are
regarding one question to Sir, Commission Sir, regarding the previous talk. There's some confusion about the dose and duration of amputation V. What is the recommendation for the liposomal amputation V?
The liposomal amputation is preferred because of its lesser cost. And generally, you start with 50 milligrams per day, increase it to 100 milligrams per day, and it is given over a course of time. And the average dose is usually anything from 1.5 to 2 grams, extendable to 2.5 grams, but very rarely it should exceed 3 grams per day. Or divided over the course of several days. Generally, people tolerate it. And you keep looking at the urine output and also monitoring the renal function.
Renal function test and magnesium also
has to be monitored, yes, at least once a week.
And
sir, one question to Mohan sir from my side. We are always in invasive fungus with the orbital complication, with complete loss of vision, limited disease with optic neuritis. During surgical part, we always encounter problems with orbital exenteration where disease is remaining and ophthalmologists are not willing for going ahead for orbital exenteration, and we continue medical management for long duration, taking into account only the paranasal sinus part. Sir, any of your personal experience on that part?
Yeah, it's very understandable, because the prognosis is so bad. Nobody wants to put their hands on a patient who's going to die. So they don't want to add it to their list. So this is why ophthalmologists and ophthalmologists by nature are very, soft people. They're not used to all these radicals. They don't see death in their cases, so they're not very happy about it. So by nature, they're not very happy about these big orbital surgeries. So this is the reason why they're not happy. But the orbital excitation, clearing of the skull base, and so on, are desperate acts to save a patient who is almost certainly dying. And as the common sense goes, a dying patient will die. So there's a very high chance that these patients will die. So you have to clearly inform the patients that these are very terminal events, and that you are going to be doing it as a life-saving procedure, and you're removing a globe which is non-functional. And then already the vision is gone, it's not going to come back. So many patients have this, relatives have this feeling that you do some surgery, the vision is going to come back. So you have to make that also very clear. So these are desperate acts in a very sick patient who's on the verge of dying, just to save life. As I already said, in my experiences, these patients don't do very well. Generally, it's a big fight. You're fighting desperately, and you lose a bit of your papillary muscles in your heart in the process. So it's a very terminal event, actually.
Yes, actually, I had 3 patients with orbital. We did, but exenteration, but they
don't very, very. I can only recall one patient in all these years in whom, when it has really gone to the stage of orbital involvement, cavernous sinus involvement, the loss of vision and so on, that we could salvage. There's only one patient. but I can remember any number of patients I've lost. So it's not a happy thing, It's not something that you feel happy about. It's thrust on you. You're forced to do something against everything, and you're fighting a losing battle from day one. You know that. So it's an act of desperation. So always it leaves a very bitter taste in your.
If no other questions,
We are
moderator.
on dot nights now 9.
Yeah,
We're
exactly.
perfect-
With
perfect timing.
Mohan sir around, we have to keep the timings. We cannot
Yes, yes, yes.
exceed.
Thank you.
Exactly.
Perfect.
on Osler-Weber-Randu disease. In fact, I think now someone has tried out using some of the monoclonal antibodies
Yeah. That's
for treatment for that, because the septodermoplasties really are difficult. They don't really work.
Frustrating. And again, Rendu Osler, it's one of those conditions where no surgical intervention really does any great help, because it's a condition where you manage one area, and then 3 months later you'll see in another area, and then you come back after some time in another area, and so on. And these are chronic patients. But like Preetham said, the vast majority of them are managed quite easily by simple cautery, by laser. Laser is particularly helpful. Contact laser is quite helpful. So you can manage them, the time, and very few of them need repeated blood transfusion. But the ones who need repeated blood transfusions are the troublesome ones. But generally, like what Preetham said, vast majority of them you can manage them over a course of time. I always used to say that when one senior ENT surgeon gave his daughter in marriage to a young ENT surgeon, as dowry he gave 4 Sturge Weber syndrome cases. So you can survive with that.
Yeah, but we do see some cases nowadays. I mean, I remember in the 90s, the first time I ever saw a case when I was appearing for my DLO exam in London. That was the first case.
I know. It's a very common case which is kept in UK exams. As whether it be DLO or fellowship, you always see a Sturge Weber sitting there. But they're easily diagnosed. It's not a problem. The problem is always in the long-term management. The patients themselves understand the problem.
I think we've had 2 wonderful lectures, and I think no one better than Dr. Mohan Kameshwaran to take a lecture on granulomatous disease of the nose. And Preetham, that was an excellent talk on Epistaxis. I completely very
really enjoyed it.
Thank you very much, both of you, for gracing us and this wonderful talk. Thank you.
Thank you for the option. Thank you so much.
Thank you.
God bless you. Thank you. Be safe.
Next week we will
Bye,
have
Rajesh.
a series on the larynx, where we have CA larynx and CA hypopharynx and management of those conditions. So see you next week.
Okay. Bye. Good
Thank
night.
you.
Good night.
Thank you very much, ma'am.
Thank you,
sir.
Vimlesh. Bye.
Thanks a lot.
Thank you.